Now let's discuss about some common esophageal disorders. Esophagitis. Esophagitis presents with pain or swallowing. Okay, that is odynophagia as the food passes through the esophagus, and there is no correlation between thrush and esophageal candidiasis. Now, in patients who are HIV positive and has a CD4 count less than 100, Candida esophagitis causes more than 90% of the esophagitis. And some other causes of esophagitis, some common causes are the use of drugs like doxycycline or a bisphosphonate, like alendronate. If caused by pills, the patient should sit up and drink more water when taking pills and remain upright for at least 30 minutes after that. Eosinophilic esophagitis presents with difficulty in swallowing, food impaction, and heartburn. Look for a patient with a history of asthma and allergic diseases and findings of rings on endoscopy. Then, what is the diagnostic testing for esophagitis? It includes biopsy, finding with eosinophils, which is the most accurate test. And treatment for esophagitis involves proton pump inhibitors and elimination of this foods causing the allergy. Also, swallowing steroid inhalers is considered to be the most effective treatment. Swallowing steroid inhalers. In HIV negative patients presenting with esophagitis, we go for an endoscopy first. But in HIV positive patients with a low CD4 count, that is less than 100, first we treat with a fluconazole, and then if there is no response, we go for an endoscopy. So the typical endoscopic finding is multiple concentric rings along the esophagus. Now next pathology of the esophagus is Mallory Weiss tear, and this is not a cause of dysphagia, but it presents usually as sudden upper GI bleeding associated with violent vomiting or retching. Okay, and it can be associated with hematemesis or plaque stool. And if there is perforation of the esophagus, subcutaneous air may also be found. How can we diagnose Mallory Weiss tear? It is diagnosed with endoscopy. And barium swallow shows nothing in Mallory Weiss tear. Most cases resolve spontaneously. And if there is persistent bleeding, an injection of epinephrine is given to stop the bleeding. Now, next one is gastroesophageal reflux disease. In addition to the epigastric pain and substernal chest pain of GERD, several other symptoms are clearly associated with acid reflux, which includes chronic cough, which is seen in 20 to 25% of patients, hoarseness, sore throat, metallic or bitter taste, and wheezing. And the treatment is PPI, which is both diagnostic as well as therapeutic. If there is no response to PPI, then do a 24-hour pH monitor. Now, why there is some presence of bad taste in GERD? So, sweet taste receptors are present on the anterior two-thirds of the tongue, and sweet is controlled by the cranial nerve 7. The bitter taste receptors are present on the back of the tongue, and bitter taste is controlled by cranial nerves 9 and 10. That is why the GERD is associated with a bad taste, because it affects the back of the tongue, which is where the bitter receptors are present. Now, treatment for GERD is lifestyle modification for mild disease, which includes losing weight and eating before 3 hours of sleep in the night, and elevating the head of bed, and quitting smoking, limiting alcohol, caffeine, chocolate, and mint. And if this does not work, we can go for drugs like PPIs, which are like proton pump inhibitors, then H2 blockers like cimetidine, nizatidine, etc. Now, we can also go for pro-motility agents like metoclopramide, which are equal to H2 blockers but less effective. And if disease is still not controlled, go for surgical or endoscopic procedure to narrow the distal esophagus and reconstruct the lower esophageal sphincter. This is called Nissen fundoplication or endoscopically suturing the LES tighter. High calcium gives ulcers by stimulating gastrin release. Now, H2 blockers reduce only 70% of gastric production. This is because histamine is only one of the 3 stimulants to acid production on the parietal cells. So, the 3 main stimulants are gastrin, histamine, and acetylcholine. And histamine potentiates this gastrin and acetylcholine, resulting in 70% reduction in acid. Whereas, PPIs inhibit acid output of the cell no matter what is the stimulant. Therefore, it is a better option. Treatment for Helicobacter pylori is not effective or necessary for GERD, and it will not tighten the lower esophageal sphincter. When there is weight loss, anemia, dysphagia, or blood in the stool, this reflux is alarming and an endoscopy is indicated. Next is about Barrett esophagus. It is a precancerous lesion and it's precancerous for adenocarcinoma, and testing is by endoscopy where we can see and biopsy the distal esophagus. With GERD, the initial endoscopy looking for Barrett esophagus is not clear. So perform endoscopy for all the symptoms of GERD like weight loss, anemia, heme positive stool. And also perform endoscopy if anyone with symptoms of reflux disease for more than 5 to 10 years. So these are the 2 cases or 2 situations where we have to perform an endoscopy for GERD. When there is alarm symptoms or there is reflux disease for more than 5 to 10 years. And Barrett is diagnosed with a biopsy, and sometimes the color is different, but the only way to be certain that the histology has changed is by a biopsy. And what is the treatment for Barrett's esophagus? PPI and repeat endoscopy every 3 to 5 years. And if there is low-grade dysplasia, we can go for PPI, ablation, and repeat endoscopy in 3 to 6 months. For high-grade dysplasia, endoscopic mucosal resection, ablative removal, or distal esophagectomy. Thank you.